Hello, my name is Patricia Ravitz, and I am a licensed marriage and family therapist. And I am truly honored today to be speaking to Dr. Gabor Mate, who is CAMP's keynote speaker at our annual conference. Hello, Gabor. How are you?
Very nice to meet you. Thank you.
Thank you. I've put together 3 topics that I'd be very interested in hearing your thoughts on. The first really has to do with the treatment of eating disorders or food addiction. And there seems to be a kind of divergent positioning of different schools in the treatment of eating disorders these days. One seems more focused on food as an addictive substance, having patients really abstain from certain foods, identify trigger foods, eat with a kind of structure and timing. And then the other, to oversimplify, is really approaching eating disorders and food addiction as more of a behavioral addiction based in early childhood trauma. And I would love to get your thoughts on this, and if you think there's someplace they overlap or if you really see them as distinct.
Well, so first of all, let's just begin with the fact that nothing is in itself addictive and everything is potentially addictive. So heroin by itself is not addictive. I can give heroin to a lot of people, or morphine for pain relief. They won't get addicted necessarily, but some people will be. Same with alcohol. Same with shopping.
Yep.
Same with any substance or behavior. So nothing is in itself addictive and everything is potentially addictive depending on the individual's susceptibility. And the real question is, what is that susceptibility based on? And then how do we address those issues? So the first approach that you describe, which has to do with the addictive potential of foods, and of course, we know that salt and sugar do trigger the release of some feel-good chemicals in the brain, and the food companies very deliberately concoct these foods to target those brain areas. That's true, but who's susceptible is not dependent on the substance. It's dependent on how their brain is utilized or set up, and that depends on early childhood experience, because we know that the brain is actually programmed by early childhood experience. The circuits and the chemicals in the brain are very much developed in response to a childhood experience. Now, what you can say about addiction in general, and whether it's food or substance or gambling or shopping, is that it's all based on trauma. There is the primary issue of trauma. And if you don't deal with the trauma, you're just not dealing with you're dealing with effects rather than causes. Yesterday, I happened to be conducting a healing session with a 36-year-old young woman with anorexia bulimia, eating disorder. She talks about when I ask people about their addictive behaviors, and I see eating disorders as on a spectrum of addictive behaviors, I don't ask them what's wrong with it. They already know what's wrong with it. I ask them what's right about it. And what is it that they like about it? And she says, it's like my secret boyfriend.
Yes.
It gives me, and in fact, literally, it's like a secret boyfriend, because when she had boyfriend, she would hide the secret from them, and she would lie and engage in subterfuge, just as you would if you're having an affair. Because what she gets from it is immediate relief. In the short term, she gets relief from the behavior. In the long term, of course, it's unhealthy, which by definition any addiction is. But there's some relief, some pleasure, some craving in the short term. Now, when you look at anybody with eating disorders or anybody with overeating problems, without exception, there's always childhood trauma there. That's just how it is. And if you don't address that, you're again dealing only with surface manifestations rather than causes. And from this perspective of family therapy, trauma is not personal to the individual. It's generational. Definitely the one who receive the brunt of it, they're the most sensitive ones. It doesn't begin or end with them. So it is to bring this answer to a close, addiction is in fact a family system manifestation of multi-generational trauma.
Exactly. Based in the family dynamics and trauma in the family as opposed to genetics per se.
Well, genetics, in my view, has very little to do with it. For all the talk about addiction being genetic based, the science for that is extraordinarily poor, and in fact, sometimes laughably so. Uh, what is true, I think, is that some people are genetically more sensitive, and that doesn't mean they're more addicted per se. When you're sensitive, you're going to feel everything more, and when bad stuff happens, you're going to feel it more. And addiction being an escape from pain, the more sensitive you are, the more pain you're going to have, and the more likely you're going to escape into addictions. But that doesn't mean that the addiction was genetic.
Mm-hmm.
It just means that you're more predisposed if things in the environment are painful.
Exactly. So that leads into my second topic, which does have to do with the patients that we treat often being very sensitive and really growing up in families that discourage the expression of feeling and really living in a culture that is, in my view, feeling phobic, where people will apologize for crying or for being sad or try to not be around people because they feel like they're inflicting that and you know, businesses that give you 3 days off for grief. And so my question is really what we can do as psychotherapists to help both to be able to tolerate the intense feelings of our patients as they access those feelings, to help them access, tolerate, and take the risk of really sharing their deepest pain, because we know that therein lies healing.
Well, so a lot of the people that you described would have been told umpteen times not to be so sensitive.
Exactly.
And you might as well tell somebody not to be so brunette, or not to be so blonde, or not to be so 5'3". You know, I mean, that's just who they are.
Exactly.
And the problem is that because the parents and the culture in general cannot regulate strong feelings, they don't know what to do with them in themselves, and that has to do with their own trauma.
Yes.
Therefore, they cannot tolerate it in the child, and so that the child's emotional expressions then trigger the parents, and since they cannot handle it, they want to suppress the expression in the child. So then the child does suppress it, and they learn very early, these kids, that for them to be emotional is to trouble and threaten the relationship with their parents. So then they become very apologetic and fearful of experiencing, let alone expressing, what they're feeling. Now, that's not restricted to parents. It's also very much present in the psychotherapeutic world, where people are often given techniques to manage their feelings rather than to experience them. And so for what the family therapist, any therapist, worth their salt, needs to be able to do is to hold space where the person can actually experience and express their emotions. For that, we have to create extraordinary safety. Extraordinary safety. Now, for us to be able to do that, guess what? We have to tolerate our own emotions, and so that the most important work of the therapist is not actually with the client, but with themselves, so that they can have vast space for whatever arises in themselves. And you know what it's like. I mean, I've been with clients and I've been triggered. And when I'm triggered, then I want to control things and I want to push things in a certain direction where I'm in charge, because I can't really allow myself to really experience what's going on. And so that's not the problem of the client, but it becomes the problem of the client because in that environment, guess what? They're back in their childhoods where it's not safe for them to experience what they're experiencing. So that's a key aspect of the work, I think, is that we do the work within ourselves.
Yes, I totally agree. And it kind of uh, leads to the third topic, which has to do with self-disclosure with patients. I noticed when I read your book, In the Realm of Hungry Ghosts, and you share a lot about your history and your process and dealing with your own emotions. And it made me wonder what you do in session, how much you self-reveal, when you think it's helpful, and when you think it perhaps would not be appropriate or could be detrimental in treatment.
Yeah, there's this arbitrary professional line that, we're not self-disclosing and that it's inappropriate. And it's nonsense.
Mhm.
We're talking about human interactions. What happens in a healthy human interaction is that there's sharing. Now, the question is not whether there's sharing or not, but what is the form of it and what is the intent of it. So yesterday in a session with this woman with eating disorder, I shared that I have a body image problem. I shared that, I'm 73 and everybody looks at me, thinks I'm rather thin, but I have a self-image of being rather flabby, which was a self-image I developed and I suppose connected to when I was a teenager. And I was talking about the difficulty of letting go of a negative self-image, even decades later, even when it's falling through.
Sorry, just 1 second. Max, here is life. Max, come here. Come over. Max, come over here and sit down. Yeah, come here. Okay, sit down, sit down. The things we can't control for in an interview. But I think, sorry.
Cindy is going to the dogs. That's what's happening here. So I shared that because I wanted to show her how common it is, her experience of this self-image, where she's got this totally distorted self-image. And I wanted to show her that this is a normal human phenomena under certain circumstances.
Mm-hmm.
Now, she found that very helpful. People always do. So the question of self-disclosure is not is it appropriate or inappropriate, but under what conditions is it appropriate and under what conditions is it inappropriate. Now, it's inappropriate if I'm doing it to get sympathy.
Mm.
It's inappropriate if I'm doing it because I'm a narcissist and I want the attention on myself. And there are such people in the healing realm, in the medical profession. I know there are, and and probably in the therapy profession as well. That's inappropriate. That's me wanting to get something from the client, whether it's approval or being liked or whatever it is. Now, of course, the client is in your office in the first place because when they were children, people wanted something from them that was inappropriate. So when I do that, I'm just re-triggering the sense that their experience doesn't matter, mine does, which is really what the essence of all trauma is. So yes, that is inappropriate. But if it's being done in a spirit of openness and just look, here we're two human beings on this journey, and I get it. I mean, if you're gonna go on a journey, you want to know that the guide that you're with has walked that territory before.
Yes.
That you're not just sort of exploring something blindly. And so for me, that's just very powerful. And of course, in all my books, I do that. And when I give my talks as well, and I tell you, and I don't do it as a technique. I just do it because it seems the natural, healthy, human thing to do.
Mm-hmm.
It wasn't like I'm going to develop this strategy of sharing. It's just something that I do. But when people read my books or hear my talks, that's the commonest comment I get almost is, that is so good. That empowers me. That gives me space to express myself. That allows me to feel what I'm feeling and not to be ashamed of my experience, So to me, it's just straightforward.
Yes. Thank you. I think we're out of time. This is just so wonderful, and I feel really privileged to have this time with you. And I know and all of my colleagues are so looking forward to the conference and having you as our keynote and having a whole day to have you share your wisdom and answer some of our questions to help us really become better psychotherapists. The conference is on April 26th in Orange County at the Hyatt Regency, and just honored and very appreciative for this time and a chance to talk to you.
Well, thank you. I very much look forward to being there in California in April. Thank you.
Yes, thank you, Gabor. Bye-bye.